Hello, everybody. My name is Valery Shafiro, and I would like to welcome you to the 5th International Meeting on Internet and Audiology. This meeting always had an online component with speakers and presenters joining remotely over the internet, but this is the first time that this meeting is completely online, which has allowed us to reach more people in more places. During the last year, audiology had it tough, just like other medical professions. We all had to change the ways we're doing things. We had to adapt and find other service delivery models. But fortunately, we did not have to start from scratch because there were many teleaudiology practices which were well researched, developed, implemented, and those who already practiced them were in good position to face the challenges of the day. Of course, this was a drop in the bucket, and now a year later, there is a growing interest in expanding teleaudiology services. And if this meeting is any indication, the registration for the meeting has multiplied fivefold from the last time it was held in 2019. So even though we are physically further away from each other, intellectually, professionally, we're more connected, we're bigger and we're stronger. And the goal for this meeting is to grow our professional networks, to find what works and what doesn't, to learn from each other, and to continue doing better in the future. Over the last year, working with my co-chairs on the organizing committee, who I will introduce shortly, we considered what would be the key themes and subjects for developing teleaudiology. And so we invited academic researchers, clinicians, industry leaders to share their thoughts and ideas to see how we can use the technology to shape the future of the profession. And so we had a great response from our community. We had a number of excellent presentations contributed. They are listed on the conference websites, and I encourage everybody to go and see them. And we can, after this session, after the keynote and the panel, we'll have an interactive session where most authors of the presentations will be present. And those who could not attend, if you go to the website and click on individual titles, many authors have recorded they had a narrated recording, their talk, and also some have excellent demos, so you can see their work. So at this point, let me introduce my co-chairs on the organizing committee who've been working hard putting this meeting together. Sorry. So this is Dr. Jill Preminger is joining us from San Diego State University. This is Dr. Laura Coco from University of Arizona. Dr. Gabby Saunders from University of Manchester. You will be seeing and hearing from each and every one of them during the meeting as they will be moderating the panels and taking the questions after the keynotes. So at this point, let me pass the floor to Dr. Jill Preminger, who will introduce today's theme and introduce the keynote for today.
It's a real pleasure to be here. I've had the good fortune to attend all of the internet and audiology meetings. And I'm just astounded at the turnout we have. After each meeting, we always say, "Are we done? Have we covered everything there is to know about this topic?" And so clearly the answer is no. So at the last meeting, and that was in 2019 in Southampton, hosted by Helen Cullington, who's a panelist today. we began to discuss how we can implement patient-centered care in e-health. And I think we've now had 2 years where a lot of people have really worked on this topic. So I'm looking forward to our discussion. So I'd like to introduce our keynote, Dr. Anne Scheck McInerney. She's a distinguished professor of family and community medicine and executive director of Catalyst, the Center for the Advancement of Team Science, Analytics, and Systems Thinking in Health Services and Implementation Science Research in the College of Medicine at The Ohio State University. She also holds appointments as a professor of health services management and policy in the College of Public Health, and professor of biomedical informatics and of pediatrics in the College of Medicine at The Ohio State University. Dr. McInerney enjoys collaborative research projects and engaging clinicians in health service research, as well as mentoring junior faculty in their research endeavors. She has authored over 300 peer-reviewed publications, 10 books, and more than 880 book chapters. She has served as a grant reviewer for 16 years for various agencies, including Agency for Healthcare Research and Quality, National Institutes of Health, Patient-Centered Outcome Research Institute, and the National Science Foundation. Dr. McInerney, her ongoing research focuses on information technology innovations in healthcare, population health management, quality improvement, and organizational development. And she is an expert in both qualitative and mixed methods analyses. She received her undergraduate and graduate degrees from Stanford University and Harvard University's T.H. Chan School of Public Health. Dr. McInerney, we're really excited to hear from you, and I'm turning it over to you. Please share your screen.
Thank you very much for this opportunity and for the kind introduction, Jill and Valerie. Thank you for the help with this. To start with this, I do not have any financial nor other conflicts of interest to report. And I'm just going to go ahead and get started talking about the learning objectives for this particular presentation. There are 3 learning objectives. The first is to really help you to be able to describe the rapid shift to telehealth modalities that have resulted from the emergence of COVID-19. Then look at the benefits. So as Jill said, I'm at Ohio State University. To start with this, I do not have any financial nor other conflicts of interest to report. And I'm just going to go ahead and get started talking about the learning objectives for this particular presentation. There are 3 learning objectives. The first is to really help you to be able to describe the rapid shift to telehealth modalities that have resulted from the emergence of COVID-19. Then look at the benefits and summarize the benefits of telehealth for physicians, and then be able to explain the potential value of telehealth in the delivery of patient-centered care. With respect to full disclosure, I am not an audiologist. I don't know how Jill found me, but she found me. But as she said, my background is really in health services research and implementation science. So that's what I am going to be presenting on as well. What is telehealth? Telehealth has been defined by the Centers for Medicaid and Medicare Services as a use of telecommunications and information technology to provide access to health assessment, diagnosis, intervention, consultation, supervision, and information across distance. So as I've been hearing about teleaudiology, it's the same thing in terms of healthcare services. And if any of you have had a visit with your provider in the last year or so, you have probably experienced some form of telehealth. And if you were like me, even though I study it, I was still startled to see my nurse practitioner in her living room instead of in an office. So that is kind of what we're talking about, is this rapid shift. I think with the way things have gone now, the opportunity for telehealth is really here to stay. And places, the New York Times, Forbes, local newspapers are talking about this value of telehealth. And really the fact that it is not going away. Part of the question about whether it will be here forever is around reimbursement, because if in most states there was a reimbursement change that enabled telehealth visits to be reimbursed at 100% of in-person visits, that has subsequently changed slightly, so that now telehealth is more about a 50% reimbursement than an in-office visit. But as long as reimbursement is there to stay, then telehealth will likely be here as well. So what does telehealth encompass? It includes a variety of synchronous, like phone or video, and asynchronous, like patient portals, online medical records, remote monitoring, and those types of activities. And virtual visits are a type of synchronous telehealth that allows physicians and other healthcare providers to communicate, evaluate, and treat patients without having to see them in person. So what we have seen in terms of telehealth is a really rapid expansion in response to COVID-19. So at OSU Medical Center, the number of virtual visits that were conducted in March of 2020 went from 1% on the first week of March, to 92% by the last week in March. So what does telehealth provide? It permits remote care for COVID-19 patients. It allows for continued care of non-COVID-19 patients while minimizing in-person contact. And it preserves personal protective equipment, or PPE, for physicians and other care providers. What has also happened is an expansion nationwide. So preliminary data from the nation show that over 24.5 million out of 63 million beneficiaries of Medicare had received a Medicare telemedicine service between mid-March and mid-October of 2020. And again, for OSU in March, 98% of their 1,800 providers were conducting around 2,500 virtual visits a day. And this is going from people that had not done this at all, had not logged in, that kind of thing. For those of us that have family members in other places, the experience, I think, of the pandemic has been clear. For those of us with elderly family members, you know, you eventually got from looking at your mom's ear, and now we learned how to do FaceTime and that kind of thing. It has been similar experience. There we are, perfect. Similar experience for telehealth providers. So why is telehealth beneficial? It really has increased access to care, especially during the pandemic when there was no other way to see providers without some significant risk. That access has been important. It's also been convenient. You can do this from the comfort of your own home. It enables communication, two-way communication, and although a little bit awkward and stilted at the beginning, it has worked. And it enhanced patient-provider communication in certain circumstances. It's also reduced transportation challenges, and especially for rural populations. For those of us in major cities like Columbus, Ohio, we still have patients that are in the rural area. So reducing that transportation hurdle has been important. It's lowered some costs. It's reduced some unnecessary healthcare utilization. I think we're at the tip of the iceberg, figuring out what the impact is on the other side of people missing visits, missing preventive screenings, and things that really did fall through the cracks during this. But in general, it's also helped with patients managing their chronic conditions because there's less no-shows and that kind of thing. Next slide, please. So what was the aim of some of the research that I have been doing? It's really aimed to improve our understanding about the benefits of telehealth for physicians and the delivery of patient-centered care. The implications are trying to figure out what opportunities support the design, implementation, and potential improvement of telehealth that supports patient-centered care. So what we've conducted is a number of studies. The first is a qualitative study design. And what qualitative in this context means is interviews. So in interviews and qualitative research, the words are the data. So as audiologists, you probably really appreciate the notion of words. Where we did this was in my department of family and community medicine. I'm not a physician, but I do work with a lot of physicians, also general internal medicine and pediatrics, all affiliated with the large academic medical center. Our participants included primary care physicians and providers, as well as pediatric gastroenterologists. We had an opportunity to reach out to that particular population, specialty population, through their association, and that's what we did. So we looked at a specific time frame between July and August, so kind of after the pandemic had hit, people weren't going home, and people had a little bit of time to talk to us. And so what we did was we conducted interviews via video conference, so via Zoom or phone, using a semi-structured interview guide. And then we transcribed, audio recorded the interviews and then transcribed them verbatim, and then analyzed the transcripts deductively and inductively to categorize what themes we saw and identify emergent topics. So if you can flick ahead to the next slide. So who did we talk to in terms of the primary care providers? One more slide, please. The participant characteristics, we saw, kind of a mix of family and community medicine and general internal medicine, mix of genders. People had been working as primary care providers from an average of 16 years, so from 3 to 41 years. And next slide, please. And then we also conducted a survey with the members of the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. So that's cleverly called NASPGAN. And pediatric gastroenterologists were responding to a survey that was distributed via their listserv. We got 160 respondents, and the data were also collected during July and August. This also provided a much needed summer project for my daughter, who was home from college interminably, and she was able to both do some of the interviews as well as some of the survey data collection. Very well mentored by her mother, which probably drove her nuts, but she had no other options. So the survey results, we were able to survey, as I said, 160. It was a mix of academic practitioners, community-based practice, and folks who did both. It was pretty well balanced across the country in terms of the different regions, and our levels of experience, again, ranged widely from trainee up to people with 20+ years of experience. So we got a pretty good mix of people. So what are the benefits from these interviews and from these surveys? So the benefits of telehealth for providers, the first one we're going to talk about is it enables greater work-life balance. So by eliminating commuting time, it also increases personal and family time. So if all you have to do is, get out of your bedroom, put on a new sweatshirt and turn on your computer, this is very helpful. So one provider talked about how, for me, having young children, I feel like work-life is not ever balanced, but I do feel that doing telehealth and being able to work from home, anytime you can cut down on somebody's commute by whatever it is, it helps, right? Next slide, please. Another benefit that was discussed is the allowing for more flexibility. So there was flexibility in terms of the visit time, the location, and it also overcame barriers to providing in-office care. So all of a sudden, childcare was less of an issue. I won't say it wasn't an issue, because there's plenty of people for whom childcare is still an issue. But from the perspective of one provider, I don't have to go anywhere. I think it's great. I think that's a great scenario. I mean, there's no reason for me to leave the house. I'm getting the same interaction as I would if I were in the office. I think it's very convenient. I do believe that some people would question whether the interaction is the same, and that's something that we'll discuss later as well. So what specifically is the value of telehealth for patient-centered care, which is really what we're concerned about today's presentation. So the first is that it reduces barriers to care. So by alleviating the challenges of transportation, both for the provider and the patient, it helps to create this access that is can be perceived as more equitable. So definitely not needing time off work. Hopefully you figured out some childcare in the background. But what we found is that patients are actually more likely to make the appointment. There's a lot fewer no-shows more frequently because they don't waste an hour of their time traveling to wherever and taking the time to find parking, which, by the way, at OCU is horrendous, making arrangements to have babysitters and so forth. Another value that was perceived was that it creates comfortable interactions. So what we heard from our providers about their experience was that it really was engaging patients in their home environment, and it eased some of the sharing of sensitive information. So the patients might be more comfortable when they're sitting at home versus in your clinic and talking to you about their mental disorders. They're in a more comfortable environment. We also saw some benefits around maintaining the connection with patients. So it provides a deeper understanding of the patient's environment, and it adds a personal touch outside of office visits. So as one, next slide please, as one provider said, I met a lot of patients' dogs, seen a lot of their gardens. It's given me a better understanding of them outside of the four walls of the office. So, you know, this particular individual was talking about having the, you know, basically going on a tour with her patient to see the garden outside and saying how healthy she was being and so forth. Another is that it involved family members. So by having this interaction in the patient's home, it facilitates the participation of the family members and also provides insight about the living environment and home care. So if you're concerned, for instance, about not having any sort of private space, and you see that you are talking to your patient and it's in their bedroom and that's all they have and they can't shut the door, the kid keeps coming in, you're going to get a sense of what that interaction is like. So there have been some significant benefits from the ability to actually understand the patient, how the patient lives, what they're doing. They also introduce you to their family, their caregivers. There's a lot of benefits from that. From the survey, we also were able to look at the usability of telehealth for patient-centered care. So we used a validated survey on telehealth usability, and the 3 questions around patient-centeredness had to do with these questions. So telehealth improves my patient's access to healthcare services. So on a scale of 1 to 5, 5 being the best, the mean was 4.4. Telehealth saves my patient's time traveling to a hospital or specialty clinic, 4.7. Telehealth provides for my patient's needs, a 4. So you'll see that this parallels a little bit about what we've been seeing in the interview data as well, in terms of saving time, improving access, and a little bit less positive around the providing for the patient's healthcare needs, because as I said, that's somewhat variable. Moving on to talk a little bit more about the usability survey results. These pediatric gastroenterologists were generally satisfied with the usability. So across all scores, the average was, across all questions, the score average was 3.9. The usefulness had the highest scores, around 4.3, and the reliability had the lowest scores. And as experienced by my inability to present my own screen, reliability is certainly still a challenge. But more research is really needed to determine how to improve reliability of the software and the systems, to determine which clinical scenarios can effectively use telemedicine. And that's a big question as well. I would say that of these providers that we surveyed, I think there were over almost 40 different platforms. So if you're a provider and you need to learn 6 to 12, that's a lot of technology to learn in a pretty short amount of time. So what are the limitations from these studies? It was really a single institution for the primary care provider interviews. The survey response rate was, is voluntary. This is not something that we gave anybody any money for. It was really just their goodness of their own hearts. And we are still working on getting the patient perspective. So not surprisingly, the patients, we have started to interview patients for some other studies that I'm doing around COVID and telemedicine and so forth, but it's been difficult to get IRB approval to bug people, basically. So we're still working on some of that. It's also a single point in time for our data collection. So we did this kind of after the pandemic adjustment had happened. So people kind of were familiar with telemedicine, but things have changed. So there's changing perspectives, there's changing levels of experience, and I think there's also a changing sense of what is or isn't appropriate for virtual visits. And then just to discuss this a little further, so I'd say in summary that telehealth presents a convenient way to deliver care, also enhancing physicians' personal understanding of patients and facilitating this patient-centered care. But the design and implementation of telehealth modalities should consider the needs of both the patients and the providers. And some other research that we've been doing is talking about patients, whether or not they have the capacity to participate in telehealth. And the answer is, some do and some don't. So device ownership, internet access, privacy concerns. If you don't have a door you can close, you're going to be concerned about what you can disclose or not. Internet access, broadband access, it's not reliable. I mean, there's parts of our state that are internet deserts. Went to go interview people in person, had the directions on my phone. There's no cell coverage. Good thing it was a small town. We were able to find the address, but that kind of thing is real and impacting different communities differently. So next slide, will telehealth persist? The former administrator for CMS says, I can't imagine going back. People recognize the value of this, so it would seem like it would not be a good thing to force our beneficiaries to go back to in-person visits. Again, I think this depends on reimbursement, because even now, if you're only getting half of your facility fee because you're not at home, where's the trade-off, and who's going to tell you whether or not you can do this? How much is this going to be your choice? So I think that remains to be seen. So in conclusion, telehealth has the potential to support patient-centered care while providing benefits to both patients and providers. And there will be continuous adaptations to care delivery. These will be necessary to sustain and support the use of telehealth, especially as the environment continues to evolve in response to the pandemic and beyond. As we know, we didn't really have a flu season last year. Pediatricians didn't get a lot of kids through their doors. So what does this mean for the future? How do we make those decision trees about who needs to be seen or not? This goes from, the nurse triage line when my daughter, who's now 21, was, 2, is this an ear infection or not? Do I need to see her or not? Now there's devices that you can put up to your ear and record and make that decision remotely. But at what point are you missing something? So, in terms of my research, the next steps for the next slide, we're conducting new interviews with additional primary care providers and trying to figure out kind of what's changed over time. We're also interviewing patients about their experiences with telehealth. We're considering scenarios where telehealth is the most advantageous. So we've heard a lot of positive feedback around the mental health care system, kids with autism, people with anxiety disorders, et cetera, et cetera. And then also we're developing interventions to support patients' use of telehealth modalities. So we're doing some research here on the role of maybe creating a digital health navigator role, working with a community health worker to train him or her how to help patients with their devices, and then also how to connect patients with devices if they don't have the necessary devices. So we found that there are a lot of resources in the community, but maybe about 20% of patients are still not eligible for getting access to those devices. So where does that pocket of money come to pay for the devices that support patients' use of telehealth so that it can be patient-centered care? And that's about it for me. I apologize for not being able to control my slides myself. But whoever did that, I think it was Jill or Valerie, whoever did that, thank you very much.
Thank you so much, Anne. That was, sorry we made you rush so much. So please start sending in your questions now for the keynote and for the panelists. But do you think we should be shaping how telehealth is going to be happening in the US over time? Like, should this be coming from the government, from insurers? Should it be coming from patients or providers? And can we learn how things are being done perhaps better in other countries?
So the answer to that, all of that, is yes, except for insurers, right? I think one of the reasons that we're doing the research that we're doing is to inform the policy debate and to get the perspective of patients, different kinds of providers who are in different areas, and that kind of thing. I think that's very important. I think to the extent that we can learn from other countries about their successes, that's also a fantastic opportunity. But I think the policy debate in our country, given our insurance system, is very biased towards what insurers will or will not pay for. And that's why telehealth was queued up, right? Telehealth was queued up and people could use this probably for the last 10, 20 years. Perhaps the platforms have evolved a bit. But the reason that we were able to go from 1% of visits to 92% of visits within a month is because the capacity is there. It was just people were reluctant to do it. And the behavior change that was forced upon us with the emergence of the pandemic made people figure it out, made people learn how to use FaceTime and Zoom and wish you had bought stock in Zoom and things like that. But I think that the difference in other countries is when the insurance industry isn't the name of the game, I think there's a little bit more flexibility in terms of what can be expected from a policy perspective. And I think there's other issues in different countries that will also come to play, which is in the US, providers are on average are paid a tremendous amount of money. And if they don't want to do it, there's a lot of places that won't push back and say, but you have to. It really took the pandemic to say, this is it. You can either see patients or not. And some people definitely retired. Some people said, no, I'm not interested. But in other countries, there is less of a disparity between income and, if you're a physician, that's a job. If you're an engineer, that's a job. It's not this kind of strange imbalance that I think we have in our country. And so I think that you're going to have the ability to have more of an informed discussion about who should be doing what. I think one of the things that's happened in the US has been a problem with kind of what do you do with the office staff if everybody leaves the office, right? So you now no longer have your the medical assistant rooming your patient. What is the medical assistant supposed to be doing? And so that's why we're trying to figure out what's being missed, and can that medical assistant be repurposed to somehow either get the digital information about weight and blood pressure and that kind of thing if the patient has the right monitoring devices, or maybe it's the training role in terms of this is how you talk to your patient and this is how you message your provider and how you ask for an appointment, and this is urgent and this isn't urgent and that kind of thing. So I think we can continue to learn from a lot of this, and I don't think that there's an easy answer. Again, even when you have the head of Centers for Medicare and Medicaid Services saying, yeah, I think it's here to stay, but what's it going to look like?
Exactly. Valerie, do you see the questions?
There is a question from David Maidment. This is more of a technical question. And what approach did you take when analyzing the qualitative data you reported? In addition, you mentioned several benefits and values of telehealth by clinicians, but did you find any negative disadvantages?
Okay, so to answer the first question, the way that we do qualitative data analysis is that we record everything, it's transcribed verbatim, and then the data are reviewed very iteratively. So the reason that 20 might seem like a little number for interviews, but in fact it was enough to reach saturation, which means we were starting to hear the same stories across the interviewees. How you do that is a coding process where you develop a coding dictionary, and so a code would have been benefits, and then a subcode would have been access, and another subcode would have been convenience, and so forth. So yes, the flip side of that is, yes, there were downsides in terms of telehealth, and I talked to some very angry people about this. One in particular was and part of this was the time frame again. It was the expectations on providers with the emergence of the pandemic were enormous. And what was happening in providers' lives is the same thing was happening in our lives. Your kids came home, your husband came home, your spouse came home, everybody's in the same space, there's not enough internet connection, and yet here is a doctor supposed to have private visits with their patient and their kids online school and their husband's or spouse is on a conference call. There's too much noise. I mean, I'm getting text from my husband's downstairs, I'm getting text, you're too loud. I'm like, sorry. So all that stress, in addition to the fact that then the providers are seeing the patients who are stressed out. And not everybody is trained to deal with this. As a director of a center, I'm not a mental health provider, and I'm seeing some of my people completely decope. As a provider, you might still not be a mental health provider, and oh, by the way, they're really busy. So you had to solve problems that you weren't equipped to do, and so that's a lot of the anger that I was hearing from some of the interviewees. I think another negative was just the amount of platforms that people had to learn. My descriptor is I study technology, I barely use it. This was proved yet again today when I couldn't share my screen. But and in the beginning there was a pause in the HIPAA regulations so that you could actually go to FaceTime. If all else failed, you could go to FaceTime and have an appointment with your provider. But that took a pause in the HIPAA rules in order to have that happen because it isn't secure. So So what that meant for the providers is that you had to learn, our institution, we all had WebEx. Well, we overloaded the WebEx system, and then we had to learn Zoom. And now we've worked on the Zoom system, but now we're moving to Microsoft Teams. So, and I, all I'm doing is, I'm just in meetings. I'm not trying to interact with patients and keep notes and chart and that kind of thing. But I think that in addition to having the, what is it, UpDocs, there's all these different softwares that they had to use, was another negative that I was hearing a lot about.
Thank you.
Thank you. I was going to go to the panel since, so we're going to move on to the panel. So please bring our panel on. Oh, they're popping up. And just a note for everybody on the panel and all of us is that please mute if you're not if you're not talking, and that reduces echo. And you still can send in questions for Anne, our keynote, but now we bring everybody into the mix. So I want to briefly introduce our panel, and then after I introduce them, then they're each going to have a few minutes just to tell us what they think is important or what they're working on right now in regards to patient-centered care and e-health. Helen Cullington, who, as I mentioned, was the host of our last Internet and Audiology meeting, is a professorial fellow and principal clinical scientist at the University of Southampton Auditory Implant Service in the UK. And she's also chair of the British Cochlear Implant Group. And she is committed to using technology to improve healthcare and communication. And so what we're learning here is technology can help with communication, sometimes not as much, but in general, very much. Anyway, Daniel Glista is an assistant professor in the School of Communication Sciences and Disorders within the Faculty of Health Sciences at Western University in London, Canada. And David Maidment is a lecturer in psychology with the School of Sport, Exercise, and Health Psychology at, I don't know how to say, Loughborough University. You can correct me when you get on. With an interest in digital interventions to increase social and physical activity and reduce non-communicable disease risk in adults with disabilities. So we'll start with you, Helen, to just tell us what you think is important about this topic.
Thank you, Jill, for the introduction. It's great to be here. I'm so excited to be at the meeting after 2 years after the one in Southampton. So it's really lovely to be here with so many more people than we had in Southampton, which is great. So that was a great presentation, Anne. Thank you so much for that. And I think I feel so happy that you and other people are doing research in this area, because I think I've felt really the last year that we've all been so kind of reactive, and I mean, in a way, it's been good that we have been able to make changes in such an agile way, and out of the adversity came innovation. But what I'm worried about perhaps is we've made so many changes to our services, and what I'm not sure we're doing is assessing really which are good changes that we should definitely keep and which are bad changes that we should definitely get rid of. I mean, certainly in my service, I think we're still kind of scrambling a little bit to know how to care for our patients. So like I say, I'm really pleased you're doing research on that. Of course, audiology patients are just us. We're all audiology patients, whether that's now or in 10 years or in 20 years' time. And the care that audiology patients need is as individual as we all are. And I think person-centered care, of course, doesn't mean at all telehealth, and not the same things, although telehealth can be part of person-centered care. And I think thinking of our patients at the Cochlear Implant Service, really what we want to be doing is providing service that ranges from us going to a care home and doing a home visit for one adult, which is the kind of the low telemedicine end of the zero telemedicine end of the spectrum, right up to a patient just managing their own care completely at home, everything being done, all the adjustments and fittings done by themselves. And I don't think, certainly in my service, we're at that point yet, really, that we're able to offer that full range of services and know quite how to do that. Personally, I've been working on a digital intervention for adults with implants and introduced it just over a year ago. And some people have absolutely loved it, but I think we have found that the take up was not what we expected. So perhaps in a way the pandemic acted against us in that respect. I think we were doing every single thing at home. You know, we were doing school at home, shopping at home, communicating at home, dating at home, whatever. So I think in a way a lot of our patients are now desperate to come back to the clinic, and a lot of staff are desperate to see patients in the clinic.
Oh, thank you, Helen. That good points, and we'll come back to these, circle back with questions. But now, Danielle, do you want to tell us what you've been thinking about?
Yes. Thank you, Jill, for the intro, and thank you, Helen. And I really enjoyed Anne's keynote because I too share an interest in implementation sciences and audiology and how we can apply it to audiology. I'll just start off by describing a little bit about what we've been working on at Western. So some of our recent research efforts have focused on implementation of virtual audiology care and how we can improve uptake, and also in the development and evaluation of tools that we can use in audiology with listeners who wear hearing aids. So this has included work such as including EMA, so real-time surveying, and we completed a recent project with children where we were evaluating real-world outcomes. And I think the findings really highlighted how capable the adolescents were, and how by using EMA, we were able to explore real-world listening experiences in a patient-centered way. And in a way that really engaged the children and gave them that sense of empowerment over the care process. So that was really nice to see. And we've also been exploring how to better support the implementation of virtual care. So please visit our PhD student Danielle DeFabio's poster on evaluating candidacy. And through this work, we've been learning how to better connect all the stakeholders involved in the care process, whoever they may be, and in a proactive way that incorporates person-centered approaches and different techniques that are patient-centered. So we're learning a lot about the key barriers and facilitators, many of which Anne discussed earlier, and how virtual delivery models are how we're starting to better understand how to break down those barriers, but we still need a little bit more work here. So I think overall, connected health and virtual delivery models can enable a patient-centered model of care. I think it's focused on individualizing health needs and desired health outcomes. And I think individualized factors can then become the driving force behind our care decisions, and they can really start to guide the care process a little bit better. And patients and their families in this type of a model are expected to be part of the care process, which is wonderful, and to play a role in the decisions of the patient and at the system level. So I think the presence of family members in the care setting is encouraged through this type of delivery model, and it's facilitated through the use of, which is one. And lastly, I think it encourages active collaboration and shared decision-making between patients and families, providers, for example. And this can be used to design and manage an individualized audiological care plan, applying it to audiology and then aligning with our patient-centered goals.
Thank you. You're talking about all of my favorite topics, and it is really exciting to see about all the great things we can do, such as family-centered care in when we move to eHealth. Okay, David, tell us what you've been thinking about.
Hi, everybody. So, Jill, you tried to pronounce Loughborough earlier. I don't even know whether that's the correct pronunciation either. I always get told off for pronouncing it incorrectly. So it doesn't matter. But I'm actually based living in Nottingham, where I'm calling in from today. So a little bit further north. So I guess for me, when I think about patient-centered care, I too, like Anne mentioned in her presentation, take a mixed methods approach with my research. So I'm interested in both triangulating with qualitative and quantitative approaches. And when I was asked to think about what patient-centered care meant to me, I often think of teleaudiology. I like to think of it a tool in an audiologist or a clinician's arsenal that they can use and they can draw upon. So I don't think that it necessarily is synonymous with patient-centered care, but could certainly help others to facilitate that kind of approach. In terms of the research that I'm interested in, I'm very technology focused. I love my tech, and I've been doing a lot of research over the last 5 or so years looking at kind of smartphone connected technologies. So these can be smartphone hearing aids. These could be kind of personal sound amplification products. Anything really that connects to a smartphone, either directly or indirectly via some intermediary device. And as I mentioned, the mixed method approach is I often interview patients and clinicians, as well as doing larger quantitative based surveys. At Loughborough, because I'm proud to announce that we are #1 in the world for sport-related subjects, I've kind of branched out into looking at physical activity, both leisure time as well as sport and exercise, and how really adults with sensory and physical disabilities can kind of be encouraged to do that. And based on my prior experience, I'm really interested in looking at kind of digital interventions. So I often cite Jane Fonda's home workout series. So these have been around for decades. So how is it that we can kind of facilitate that? And I just really want to mention a point that Helen brought up. So she kind of stole the point that I was going to make about kind of COVID related aspects. So I guess patient-centered care, there's been this huge drive for remote delivery, teleaudiology, primarily arising due to COVID-19. But I think now what we're seeing is things start to open up a bit. I definitely think that there are a lot of people there that really want to see people. I often used to refer to it as Zoom fatigue. So I think many people have probably got a bit fed up with kind of taking calls from home and things like that. So I think that, you know, there may be a drive where we almost go the opposite direction, where we do want to start seeing each other in person when that's permissible.
Well, thanks, David. Thanks for the correct pronunciation. And Anne, I wanted to mention to you that us folks in audiology, we discovered qualitative research, I'd say about 15 years ago. So we've been doing quite a bit lately, and it's added so much texture and context to our quantitative work. So we've got about 25 minutes or so, or 20. So let's go to questions, and I don't see them. So Blair, do you want to ask the first question?
Sure. Yeah, we had a couple of questions, and I guess it was refreshing to hear both the positive and the negative sides of what teleaudiology or telehealth in general entails. I think one theme that comes through the questions is the sort of digital literacy, right? When we're surveying people about their experiences with telehealth, is that a representative population? Are there people who are just so behind or not even just comfortable with this that they're just not set for telehealth? And you can see that across the age groups, you can probably find some rather dramatic differences. So I think the question that comes up is how representative what we're learning is about patient populations.
Anne, do you want to handle that, and one of our panelists?
Sure, I can talk about that, and I'm guessing that David might have something to add to that as well. I would say that looking at digital health literacy is something that we've spent a lot of time looking at, and there's different ways to look at it in terms of devices versus what resources do you have? And we've actually developed a model in terms of patients' capacity to use telehealth, and it's got 4 dimensions. One of them is willingness. So are you willing to use something other than a smartphone, fill in the blanks. Do you have the resources? Do you have the technical resources? Do you have the human resources and that kind of thing? do you have the capabilities? Are you able to do this? And I would say in terms of the audiology population, if you have somebody that's hearing impaired, my mother-in-law is severely hearing impaired, and trying to figure out what's the best closed captioning option so that we can talk to her, because she lives in California and we live in Ohio. And there's a fourth that of course I've forgotten now, because I distracted myself. But anyway, so all of these things come together in terms of a patient's or person's capacity to use, self-efficacy. So do you believe that you can do this, right? And I would say at some level, people's self-efficacy has been challenged in this pandemic, right? So maybe I didn't think I was capable of figuring this out. And yet, since everybody else has to do it too, you know, I had to become my own tech resource because I was too paranoid to let someone in the door. So anyway, these things come together in terms of a person's capacity to use telehealth. And it does vary. It varies based on things that we've now seen, right? If you look at issues around disparities in access, disparities in care, disparities in health outcomes, all those things can be mapped on to patients' capacity to person's capacity to use telehealth. So if you address that capacity, you really have to look at all those things. And that's why I propose this model of a digital health navigator, right? Just because I give you a device doesn't mean you think you can use it. And I would say there's certainly age differences, but it's not everybody. We have another study that we did that was all hospitalized inpatients, and we were looking at their use of an inpatient portal. So MyChart Bedside is what it was called as an EPIC model. And, you know, looking at the biases that are inherent in terms of a study like this. So who is getting it's on a tablet like an iPad, but not as easy to use. And there's all sorts of issues with that. But, you know, somebody has to give the patient the tablet so that they can access the portal. So what we found kind of midway through the study is that there were care team members that were not giving somebody a tablet just because. And the becauses were anything from, you know, oh, he's too old, or she can't see well, or whatever, to I thought he was going to run off with it. I didn't trust him. You know, they're stealing the phones. Why wouldn't they steal the tablets? This kind of, you know, this is the issue of structural racism, right? You've got these biases that are playing out in terms of expectations in an institution such as ours. And how does that affect your ability to leverage telehealth if you don't even have the opportunity to practice and learn in a safe environment? So there's a lot of things around this inequitable access and inequitable capacity that it's not, that the answer isn't a simple no, yes, our studies are biased. Yes, absolutely, they're biased. They're biased by who picks up the phone, you know, who doesn't pick up the phone, that kind of thing. But what can you do about this bias, and how can you go and reach those populations beyond kind of the standard? So.
Thank you for bringing up those somewhat depressing points, but it's so important that we're thinking about this as we do our research and as we provide our services. Access, and your model is really interesting. Thank you. Did anybody have anything to share else, or should we go on to the next question? Oh, David, go ahead.
I was just going to say that when we think about age and digital literacy, there's often this, I like to do a Mythbusters section at the beginning of many of my presentations, highlighting that, particularly with older adults, that you know, in the past decade, they've gone through the highest growth in terms of digital literacy, in terms of smartphone ownership. So I definitely can relate to what Anne was saying about biases. You know, research has shown that clinicians may be reluctant because of these pre-existing ideas that they have, and actually it's important not to rule anybody out. You know, just to be aware that if there's something you can offer, just ask, because you might be surprised. I know research I've done, I've had 90-year-olds using tablets that's been really surprising. So that's just the only point I would make.
Danielle?
Yeah, thank you for all those great points. I think we're looking at something similar within audiology, and and kind of from the direction of looking at candidacy. So at a micro level and a macro level, we're looking at all these different factors and evaluating it at the individual level and per appointment, and then looking at how the implementation went. And at the end, I think we really hope to learn which of these factors are really important and whether or not we should be addressing those as we're deciding who we should deliver care to. And I think the provider bias factor is coming up as one that I think is more prevalent than maybe we all understand it to be currently. So hopefully we learn more about that. And it's been a really interesting project so far.
I would echo that the other issue with the provider bias is it goes both ways, because the other thing that's happening is that the patient may not trust the provider. You know, your comfort working with your provider is not the same as somebody who's Black or brown dealing with a white male physician, for instance, right? And that's the other thing that we're finding, is that the trust in the provider impacts your perceptions of your self-efficacy managing your conditions, right? And that kind of thing. I would say that the one age thing, it has nothing to do with digital, but the one age thing is whether or not you kind of believe a doctor is God, right? That's definitely something that's an older generation thing that I'm still dealing with my mom. But I think other than that, I love the Mythbusters concept. I mean, it's true. You can't make assumptions, and I think that goes for all of this. You can't make assumptions and think you know about this other person. And I think that's another thing the pandemic has taught us. Like, there, you know, there's what you know about this person, and then there's all this other stuff that you don't know. And you need to kind of give people the benefit of the doubt and give, you know, little kindness, little patience, and that kind of thing. But I think it's wonderful that you're starting to study these things and really think about, you know, what do you do if you find out that providers are biased? How do you do it? You send them to a seminar, do another CME? We know that doesn't work. So what are you really going to do about this? So I think that's great.
Yeah, one thing that's really exciting about family-centered care and the pandemic is now that when you're having these telehealth appointments, you can bring in family members from other locations into the appointment, and that really makes a difference. Valerie, what's our next question?
So one question, I guess, speaks to, this is from Jan Willem Wasman. He's asking if people had fear of COVID, and now that people will go back more, will have opportunities, will they become more critical about telehealth? And so I guess related to that, there's a question from Gabby Saunders if clinicians should be promoting telehealth. So I made it into a two-folded question. You can take either part you like.
I think both are true. Both can be true, right? So we're getting more excited to go out and you know, be a part of the world and engage. And I think we have higher expectations now. We kind of feel like, you know, we should have it the way we want it, right? I want a telehealth visit. I want an in-person visit. It should be my choice. So I think that's going to be something that's going to be complicated because it isn't necessarily going to be your choice. And I think the other thing that's happening, and I don't know very many people who have a good handle on this, is that there are some visits that are appropriate remotely, and there are some visits that are not. And to figure that out for each type of visit is a really big question right now. So when I was working with these pediatric gastroenterologists, they're talking about, oh, you know, I don't know squat about gastroenterology, thankfully. But, you know, they're talking about, well, you know, the belly sounds, and you can hold a phone up to your belly and listen to it, you know, so certain things apparently you can do and certain things you can't. I don't know how quickly we're going to get a handle on that. So I think that's going to be the other side of it, is that there's going to be a lot of provider directed decision making about what's appropriate for an in-person visit or not, that maybe some people will chafe at, right? So I can't get a mammogram remotely, which is fine. But do I have to go all the way into the breast center in order to do that and then expose myself to everything? Maybe there's a different way to do this. So if you think about kind of all of the things that we've had to figure out how to do in the last over a year, And now you say, okay, now you have a choice. Whose choice is it? And I think that's the big question. Is it the provider's choice, the patient's choice? If we're looking at person-centered care, shouldn't it be more the patient? But this probably depends on those of you in other countries to look at the reimbursement and say, is that something that might be more flexible if the insurer isn't directing the payment?
More comments from the panel?
I would just say, in addition to, say, a reimbursement perspective, also there's the consistency across clinicians, managing different patient expectations, because they might have a friend who lives somewhere else that has access to some of these remote technologies, which is brilliant, but then another individual that might need to do something else. So I guess it's kind of, and I think Anne mentioned having all the 40 or 50 different platforms as well. It's just that consistency, and I think that can be a barrier for both the clinician and the patient perspective.
And I was just going to add that I think, although we don't have it all figured out, the pandemic and the efforts that we've all put in has given us a really nice opportunity to evaluate what has worked and what hasn't worked, and improve on those things that hasn't worked. And just to follow up on David's point, I think just the basic scheduling process and how that works for each appointment is such a big factor when it comes to clinical barriers. And then the triaging, like Anne mentioned. And so I think we have some work to do around that to help with the flow of these appointments.
I'm thinking about bias and assumptions, and certainly it's been the case that a year ago in my centre, the clinicians would say, there's no way we can do that. Our patients are elderly, our patients are deaf. They can't do that. So it's been fascinating, really, that in a lot of cases our assumptions have broken down, and in fact for some deaf people, communicating online is better for them. It's more of a level playing field, it's more accessible to them. So I think that has been good. I think I'm just thinking about bias in general and thinking, we've all done this kind of unconscious bias assessment to see what our unconscious biases are. Maybe we can add tech awareness to that. Are we looking at somebody and thinking, because of your educational status, because of your age, you might not be technically able, when in fact that's just not something we can assume at all, but maybe we are doing it. In the UK, as I said, I'm chair of the British Cochlear Implant Group, and probably the number one thing that patients and families complain to the patient user group is, like David says, consistency across centres. And especially with cochlear implants, when patients travel a long way for their appointments often, this is going to be an issue that some patients are going to be saying, oh, my centre is happy to do all the pre-assessment counselling remotely, my centre isn't. So I don't know the difficulties with, of course, this should be the patient's choice, but logistically it's a massive challenge for the centres to offer appointments remotely or decide what to do remotely in person. Should we be deciding this kind of as a country that, this is what we recommend? I don't know. It just doesn't seem the right thing to do either, really, but I just don't know how to make it equitable across the country. I don't have any answers to anything, as you can see. All I'm saying is just kind of problems that are in my head the whole time. I have no answers.
Well, and I think you bring up such an important point about equity and access, because I'm sitting here thinking, here we're doing a usability study or writing up a usability study right now of a new technology, but our subjects are not diverse. Because how do you recruit a diverse subject population who's gonna have representation of minority populations? And if anybody's got the answer to that, please let me know. But we're not even, it's so difficult to bring them in to help answer the questions.
I mean, that's only going to happen, Jill, isn't it, when that is the only option. So if the only option is a remote solution, a remote care pathway, then everybody has to do it. And then you can do research on anybody, but the problem is, and this is the case with all my research, my population have just self-selected themselves. Do you want to do remote care? Yes, I do. Oh, do you like remote care? Yes, I do. It's just not representative in any way. But then if we're going to say this is the only option, how is that our person-centered care? It just is so difficult, isn't it?
Right. And does that mean the people who, you know, so what about these underrepresented groups? Are they even going to then miss out on care? It's very discouraging. Valeri, do you have a new topic for us? New question? Something more happy?
Yes, actually, I'm not sure if it's happy, but it is certainly important. There is a question in the chat from Shay Morgan. How do you think all of these shifts toward remote visits have or have not impacted or should not impact education of the next generation of clinicians? Because there's a number of interesting questions, and some of them will be addressed at later points, at later panels, but I think the education is not built in. So it is good to think about how the education of future clinicians will be impacted, has been impacted, and what should we strive towards.
So that's
Oh,
actually,
great.
that's a great point. Sorry, go ahead, Joel.
No, you go.
Okay. And we actually did ask some of the providers about that because we are at an academic medical center. And of course, instantly, there were no medical students involved in any care whatsoever. And as time went on, there became the ability to, and then part of the issue was some of the platforms only allowed one person. So if, for instance, you needed an interpreter, how did you get the interpreter in the visit as well as the provider? And that was complicated. As time went on and the providers were able to go back into the office, that is one of the things that we've heard about, is because the learners have not had enough in-person hands-on experience to feel comfortable. And I think that's been something, you know, basically all the med students pivoted to babysitting the faculty's kids so that this care could continue. And that, I'm not joking, that is kind of what happened in a lot of situations here. So then when the med students were back to kind of remote learning, OSU is a medical school that has very, they have longitudinal practice, so it's very hands-on. They have small groups that go through everything. And I don't think they have a good idea yet in terms of how that is going to impact over the long run. I do think that there's more skills that are being taught about how to manage a visit remotely and that kind of thing. I don't think it's very well organized. I think it's more on the fly. And to get to David's point about consistency, I'd say there's no consistency. So if you look at kind of the changing guidance around, you know, PPE and how that flowed over the last year, I would say that's basically the same thing that's going on with medical education and residency and so forth. And if anybody, you know, has followed the news, I mean, even vaccination access, you know, not everybody who needed a vaccine got the vaccine first, and not everybody who needs a vaccine has gotten it yet. And so when you look at that and its impact on the ability to learn and deliver care confidently, and trust the institution to take care of you. I mean, that's a whole nother issue that we have seen some fallout on. I think that it leads to more questions about, you know, what's the long haul for, you know, medical education, graduate education, to say nothing about undergraduate and school age kids. What I see David has a crib in the background. I'm kind of jealous. That's probably the least impacted in terms of this.
So we just have a couple minutes left. It looked like our panelists had something to say about this. Danielle, did you have something to add to the conversation?
I would say just bringing it to the field of audiology, I echo the need for more training. I think at the university level, it's not happening in a consistent way where our graduates, our clinical graduates are learning about this topic so that they feel confident in offering it to their patients, and their patients can make an informed decision around that. But I think we have such a wonderful opportunity right now in terms of practicum hours and offering those virtually for our students to get hands-on training that way.
Thanks. And David or Helen, do you have some final comments to share?
I would just say from a training perspective, we need to ensure that the people delivering the training are also confident and competent, because there may be that discrepancy as well. So again, like Helen mentioned, I'm not offering any solutions, probably just more problems, but I guess it's important that we are aware of these things so that we can actually then start doing something about it.
Helen, do you want to close us out?
Well, and it's just like anything, isn't it? Like David says, just awareness of what the issues are is absolutely key. I mean, it seems like for the past 18 months, everything has had a pause, hasn't it? Certainly medical education, practical education, our children's education. And I don't know, I think we're going to be feeling the repercussions of this for a long time, really, but I guess we have to be aware of it and try and move forward as best as we can.
We'll look at us right on time. Thank you so much, Anne and our panelists, for this great opening panel and keynote. This is such an interesting topic, and I think we'll be coming back to this throughout the presentation, throughout the conference. And so, Valeria, you want to tell us about what's happening next?
Sure. So we're going to have a 10-minute break and reconvene and half past the hour. There is a different link for the interactive session that is coming up next. I will post it into this chat just in case, but you can also go to the conference website, internetaudiology.com, click on the program and click on the link there, and you should go to that WebEx meeting. I will also post a link here in this chat to a single PowerPoint slide just for people who forgot what to do once they join the interactive session. Basically, the instructions, once you join, you should see breakout sessions, breakout rooms, and you should find that button in your controls, and then you will see a list of rooms which have the same letter number codes as the presentations shown on the website. So you can always just join the room you like based on that letter number code and the title that you can look up on the website. And you're free to go from room to room, just you would at any kind of poster session and so on. One other point I wanted to make is that you will also be able to chat. So if you cannot find a specific person in the room, you can chat to them through WebEx and see maybe you can arrange a meeting this way. Finally, after the interactive session, it will stay open for a while past the hour, but you're welcome to go to the Gather Town, which is also linked in the program, and interact with people there, because you can also go and see each presentation there. Some of the authors will be there, perhaps, and you can also meet other participants. So with that, I hope you enjoyed our first session of this meeting, and I will see you shortly in the breakout sessions. Thank you.